Okay, so I think more people are probably going to show up. Everyone can see on the screen that is April right there, and I think I've introduced her like 6 times this semester already. Of the coming,
Feel like you're overselling what's
yeah,
happening.
the coming soon speech has appeared at the beginning or the end of about half a dozen lectures.
Oh,
So everyone already knows the history of undergrad together, but can we start with we're at Willamette. Everyone knows
mm-hmm.
it because Travis already came in, and it's you, me, and Travis,
Mm.
the three of us, yeah, at undergrad together.
You
So
guys are all still recovering from Travis's lecture, I'm guessing,
a
like
little
emotionally.
bit, a little bit. Uh, but so can we start with the decision for PT and the interest in PT? Pre-PT school, what was your? How did you decide to go into PT?
Okay, well, I can just do, yeah, like a history of how I got to where I am now, if you guys are interested in that. Um, so in undergrad, I was sure for a long time that I wanted to be a physician. I wanted to be in neuro in some capacity. I didn't know if it was surgery or just general neurology. But I also enjoyed PT because that's where I worked. I worked at a clinic in town, a little outpatient clinic. And then finally, towards senior project, which I assigned, I did not get to pick my mentor for our senior thesis. And if Courtney has ever mentioned him before, his name is Peter Harmer. Is a brilliant, brilliant person and probably made me cry every day. Just
I think the world is shy on harmers these days. So
he
just
he was
for perspective, I mean, he publishes the New England Journal of Medicine in
he was an
Lancet.
Olympic fencing coach. He
Yeah,
was
yeah, he was
yeah.
a NAC winner, a national champion in fencing. He won the U.S. championship. He won, I think Vet 40 or Vet 50, something like that. Well, hard ass though, super hard
Super
ass.
hard ass. So anyway, he told me basically, if you want to be in med school, you're gonna have to work a lot harder. And I was like, oh, well, that's a bummer. So I did, and I worked super hard, and I took on a thesis project at a physical therapy clinic. And I was not really, I was kind of disappointed with therapy. I thought this isn't the field that I love. I'm just gonna keep my plan. And Peter told me that I could continue doing that. Go ahead, but do this thesis, and you might enjoy PT. And I thought, I don't think so. I don't think he knows what he's talking about right now, which he always does. So I was very wrong. And I finished my thesis, which was at a PT clinic, and it was investigating kind of an experimental use of a well known treatment on different body parts. And it was really, really interesting. And I took that actually to a shadow that I was doing at a neurology, the neurology center at Salem Hospital. And I was talking to them about it, how excited I was about it. And they were like, yeah, we don't do any of that. We don't care about that. And so I was kind of bummed out that I had misjudged PT. I thought it was kind of like this not exciting field, and I really wanted to go into the exciting field of medicine. And then the more I learned about both, I discovered that PT was actually more patient centric. Like you spend more time with patients, you get to see them, you get to know them. And medicine was not. It was how many people can you see in 15 minutes, and kind of delegating a lot of tasks to other people that you should be doing yourself. So a lot of it, like investigation, looking at symptoms. So I changed really quickly right before I took MCATs, which I don't know if Courtney, if you remember Natalie, my roommate,
Yeah, yeah, yeah.
she was the only one that ended up taking them. There were like 6 of us. We were all going to take them, and she actually is the only one that ended up doing it. And she's a pharmacist now. So none of us went to medicine. But I decided to go to PT school. So I applied to all the ones I really wanted to get into. And my now husband was in Tennessee. That's where he's from. So we moved to Tennessee, and I went to PT school. I had to take quite a few prereqs. I did not take enough chemistry at Willamette, apparently. And I applied. There's a ton of schools now. There's quite a few. There's like 3 in Oregon. There was only 1 with a pretty low acceptance rate, but I think now it's grown as a program. So I got into PT school, and it was kind of shocking what it actually was. I was kind of expecting like, oh, they're going to teach us how to teach people to exercise. So kind of similar to my XI background, like that Courtney took, but it was not. We had maybe 2 weeks of that. And the rest of it was differential diagnosis, how to read an MRI, how to interpret an EKG. We had surgery rotations. You have to take 2 years of pharmacology. At least my course was 2 years of pharmacology, which is actually one semester more than you would have gotten in med school. So PT school was not what I was expecting at all. It was very tough and there were no breaks. It was just 3 years straight through. We had a week for Christmas and that was it.
So your classmate, your response to PT school was positive, even though it was different, or it was negative?
It was, okay. I chose PT because I was then more impressed with how much patient time you got rather than medicine. Like you actually got time to spend with patients, but I wasn't expecting much from school. I kind of thought, oh, this will be like not that exciting. And it was incredibly enriching. It was amazing. I was so impressed with the things that we got to learn, because it's in-depth all systems evaluation without the ability to order like an MRI and then look at it a little bit later. In some states, we can order x-rays and MRIs, but not here. So it was, how do we decide if someone has an air pocket in their lungs versus a pocket of solid fluid without looking at the lungs because we don't have imaging. So we got to learn how to differentially diagnose that and then treat in a clinic, which was just absolutely amazing. So I finished up my 3 years at Tennessee State University, which I highly recommend going to a state school. It will save you a lot of money and you get the same education because they all have to meet the same basic criteria. And then I did my residency at St. Thomas in a spinal surgery ward and a fellowship at Vanderbilt in their genetics department, working with kids with neurodevelopmental disabilities. So that was pretty cool. And if you've ever been to Vandy or experienced Vandy, it's a really amazing experience. They have fantastic clinicians there. And I worked for a little bit. I was the director of spinal rehab at a spinal and brain surgery clinic in Tennessee. Then I moved here and I made a really big shift in Salem, Oregon to home health. And I do neuro specialization. So I work with people with neurodegenerative diseases, the other end of the spectrum.
So you had that experience with kids, sort of. Okay. Clinical.
We were in the NICU a lot.
Health. Can you talk about the difference between clinical and home health?
So home health is, are there people here that want to go into home health? Courtney was saying there's a couple of you that want to be PTs and want to go into home health.
Open up the comments, people.
Oh, okay. I'm ignoring the comments, sorry.
But people, open up the comments if you have specific things that you're hoping to get answers to get clarity on, topics to explore. Type stuff in the chat box, or if you unmute yourself, I think it'll be fine with the overhead speakers, probably. So speak up or type into the chat box. And I think some people were hoping to go into more of a home health.
Okay.
Session.
So clinical work, as far as, well, my fellowship was different than outpatient clinic work. There are outpatient and home health PTs. I don't have a cocaine habit, so I don't think I could do that job, but you would have to do that because kids are absolutely insane and difficult to work with. But as far as my fellowship, because we were in the NICU, it was very high needs babies. So that was much more delicate. It wasn't as much therapy as it was keeping the kids okay till they could get medical treatments and preparing the family for what would be coming as they developed. So that was a little bit different. Outpatient clinics they're fun and they're clean and happy. And home health is, you don't know what you're walking into. So I've walked in to the middle of a domestic dispute and asked the lady if she needed to get in my car and we needed to leave. I've had a gun pulled on me. I've had a gentleman keep trying to get me to his basement. So it's not, you have to be very prepared.
For the narrative, can you do some details, beginning, middle, and end of a couple of those encounters?
Yeah. So the domestic dispute one is one that actually comes up pretty frequently. We go to people's homes, and they don't lie to you in their homes. They can't. So when they go in to see their doctor or see you at an outpatient PT clinic, they're going to show you the best version of themselves. But if you're going into their home, you're going to see that they have nothing in their fridge except for mixers and vodka. Like, you're going to see that they don't have food. You're going to see they don't have clean clothes, or that their plumbing is broken and they're using the shower. Like, you're going to see all of that, and they can't hide it from you. So they tend to be who they are. So if they're going to fight, they're going to fight in front of you. This lady her boyfriend, I guess, was actually the patient, and he was a severe alcoholic, and they were in a huge fight, and they didn't hear my car pull up, and I went to the door and I saw her screaming and running down the thing, and he's screaming, things are flying. And so I just stopped and I said, "Do you need to get in my car? Do we need to leave?" And she just immediately froze, said, "Nope, everything's fine," and walked back in the house. So I followed her in there, and he was trying to be on his best behavior, but he was clearly very, very drunk. So he was fun to deal with. But it ended up being fine, and he ended up actually going into, I think, a rehab clinic like shortly after. So
A different kind of rehab.
Yeah, yeah, different. So home health is a troubling one for new grads, because you're by yourself and you don't have people to bounce ideas off of. So if you're not really strong in things like differential diagnosis, you could miss something. If you don't feel comfortable taking control of a situation, that can be very difficult. Yeah, it's just you out there, and you have to sometimes go into odd situations. I had a lady that was a frequent flyer. She was maybe 28, 29 at the time. And she would try to cancel an appointment because she was having alternating diarrhea and constipation. And just knowing her history and the differential background that I had, I was like, "You need to go in because I think there's something wrong with your gallbladder." So she went into the ER, and they took it out that day. But I could have easily just said, "Oh yeah, you're having stomach problems. I'll be back next week." And it could have been much worse. So I think you have to be comfortable with that.
More intimate than it sounds like than a physician would have, or other healthcare practitioners.
Absolutely. Yeah. Half the time I'm running through occupational therapy things. So their ability to do ADLs, can they shower themselves? Can they get dressed? Can they make a cup of coffee? Social worker stuff. Do they have enough money? Do they have food? But what was the main appeal for home health? Yeah, that was it. It was challenging. It was never boring. And I got to treat the whole person. I get to treat the whole person. I get to, like I was saying, see if they need social services, see if they need APS, see if they're self-neglecting, which I have run into before. See if they are a candidate for a study. I got a patient into a brain tumor study up at OHSU, and see if they're in need of church services. One lady couldn't walk and didn't know that the church would bring communion to her house, and she didn't really know how to go about fixing that. So half my time that day was sitting on the couch with her, calling churches to see if they would bring, pre-COVID, communion to her house. So, I mean, a little bit of it was therapy, but a lot of it was just treating the person, which I really, really enjoyed, and I still enjoy.
Okay, so how do you get a patient? Being home health, how does a patient, how do you know who to go to, and what do you know going in?
So like in contrast to outpatient, where if you have direct access with your DPT, you could see a patient without a doctor's orders, home health has to have a doctor's orders. Mostly because Medicare mandates it, and Medicare sucks and hates everyone. So they'll have to approve it and all of that. But we get an order from either surgeon's office, or it could be a family member that calls in and says, to their doctor, hey, my mom's not walking well, can you send an order in? We get the order, and sometimes we just get their name and address and diagnosis. Sometimes we get a whole chart, just depends. I got an order that said trouble walking, and that was it. And I showed up and I was like, oh, because your leg is amputated. Well, that's cool. That could have been on the note, I feel like just something would have been helpful. You see shifts in the level of care that you're able to provide in home health. Yes. Yes. The last couple of big changes, especially, I believe it was maybe the beginning of 2020, where they started PDGM, that's what it's called, where they started paying or allotting amounts of money based on patient diagnoses rather than pay for service. That shifted a lot because it was no longer up to our clinical discretion what their treatment plans needed to be. Now it was, is the company going to lose money if we see more than 13 visits? And it was based on Medicare's own, I assume they just pull the number out of their ass, honestly. I don't know. That's what they do. They do everything they can to not pay. So yeah, we do see a shift in what we can do if we're limited in number of visits. So I might say, okay, I'll see you once every other week, and I'm going to write you this really extensive program rather than 3 times a week, followed by 2 times a week, and scale it down as you get better and then send you to outpatient. So we also saw, not just in level of care I can provide with patients, but Medicare used to pay for bath assistants. So HCAs is what we call them. And all of a sudden they have wrapped that into therapy. So if they need a bath every week, that cuts down on the speech, nursing, PT, and OT that the patient can get. And luckily my company they have taken a big hit. They are willing to lose money on patients so that the quality of care isn't compromised. But other companies, they've gone from, hey, you have 12 visits to you have 3. And it's really unfortunate.
So if a patient is being seen every other week, you're probably doing more total work for less money, I assume. If you have to write, like let's say you're a music teacher and you sit down with the student and show them the scale or the song and say, I'll see you in 3 weeks, but here's what I want you to do in those 3 weeks, as opposed to I'll see you tomorrow and that's our time together. I imagine you must work more the less you see people.
There's a lot more long-term planning and a lot more background work that I do. But in general, home health is a lot more paperwork than any other setting. So if you hate paperwork, home health is not the place for you. There is a lot. Like there's a certain type of visit that's the initial visit where we go through everything for the patient. We go through their medications, we look at their rooms, look at their cars, we do a full body skin check. If you don't want to do that, don't go into home health. All of that, the visit, we're allotted 2 hours, and I'm very good at them, and it takes me about an hour. And the documentation, which I, again, am very good at, and I will brag all day long about this because I'm really good at it. It takes me, if I'm uninterrupted and everything goes smoothly, 45 minutes per patient. There are other clinicians where that documentation, they miss the 48-hour window to finish it. It's just not done in 2 days. So there's a lot of hoops to jump through and a lot of documentation. That's background work. Like this morning, I was up at 5 a.m. to finish some chart notes.
But it sounds like you don't know much going in. Having difficulty walking. You probably have a name, maybe like an age.
We have a birth date, a name, address, their insurance information, and a diagnosis. The diagnosis may be hypertension. We don't know. And we have to figure out what the actual diagnosis is. So it's always fun.
What are the first things you look for when you go in? Probably safety, but that aside, what do you immediately look at on the patient?
On the patient? Like after I'm done just kind of introducing myself and doing the talk?
Yeah, will you walk us through what an interaction is like?
Yes. So they're not standard, because if I go into a memory care and the person's really combative, I got to condense my work pretty quickly. But a standard regular old patient, like low back pain or something boring, I would walk in, take notes of their house. So how many steps do they have? Is the floor covering safe? It's their lighting situation. Is their driveway safe? All of that good stuff, because home safety is one of the things we have to write about. Then if they answer the door, I'll assess their gait as we walk back to wherever they want to sit. Look at the state of what they're wearing. Have they showered? Is there like dried food all over their clothing? Is there blood? That kind of stuff. And if it's not them that answers the door, it's a family member, then I try to have them take me a roundabout way so I could get a view of the house. And then I see where the patient's sitting. Then I talk to the patient for a while. We go through very boring paperwork on the first visit. Then I do a neuro check on most everyone, just because my patients are older and they need a neuro differential. So we'll go through, VOR checks, balance, do ocular checks. If I suspect anything or I know they've had some kind of brain injury, I'll go through several checks for different types of agnosias or aphasias. I do a strength check, sensation. I don't do reflexes because I don't care. And it doesn't help me with the clinical picture that much. And then I will do a skin check. So everything head to toe to look for wounds, funguses, incisions that they didn't tell me about. Found those. Also to kind of double check for things like scabies, which I have found on patients. And I'm like, oh God, I'm so glad I didn't sit down. So looking for those, or any kind of signs of like abuse, like burns or bruises where they shouldn't be. Also pressure ulcers. That's a fun one. Oh man, I wish it wasn't a HIPAA violation, because I have these pictures saved on my work computer of a incision that it just fully dehisced. It was an abdominal one. I mean, just fully, like this much just dehisced. And it was so gross. I took pictures of it, which was probably not okay because I didn't get permission, but they're on my computer.
How often do you encounter these problems in people? In your patients, how often are there like weird complications that you weren't expecting?
Like 80% of the time.
Okay, so you are expecting them. It's unexpected that you wouldn't encounter.
Yeah, if they're normal, I'm like, I don't know what to do. I'm so bored. You're fine. Go to outpatient.
I guess if they're normal, they can probably leave the house and go to a clinic.
Yeah. If they're functional, the goal and the expectation is that they will be at the next level of care. Our goal is to get them from completely dysfunctional or non-ambulatory, whatever, bedbound, to a higher level of care. And sometimes that higher level of care is a skilled nursing facility, or sometimes it's lower level of care and we have to talk about hospice. But the goal is, once they can get up and move around, they are supposed to get up and go to the next level of care. So the people I see are not there yet. They're disasters, they're train wrecks.
So some of the other scents that you might encounter when you go in, if they're unable to leave the house and you're occasionally detecting a fungus, what are the smells like when you go into the
house? You will never forget the smell of C. diff. If you guys have ever worked or been in a hospital, or Nathaniel's over there nodding. You know what C. diff smells like. It's not good. You can smell it from outside the house. A lot of animal smells. A lot of people that can't move around can't clean up after their animals. So it's either animal feces or dead ones sometimes. I've had a few hoarders. They had dead animals.
If you're hoarding a dead animal, I think there's a
well, they didn't know it was dead. They couldn't get
behavioral.
They couldn't get to the room. They couldn't get to the room where the animal was dead. Okay, hold on. Is the differential of normalcy of a patient mainly dependent on age? No, younger people are weird too. Nothing will make you feel better about yourself than going to some of these people's homes and seeing their lives. You're like, I am fine. I'm good. I'm a normal person and my house is clean. Like, I eat normal things. You will think that about yourself. I'm sorry, I rambled on about the skin checks, but skin check, strength check, mobility check, and then I make a plan with them, usually. Sometimes call the police. I don't do ortho unless I have to. So I don't get a lot of surgery patients. We have a lot of surgery patients. It's just I don't see them as much, unless I can help it. Like, yeah, I see neurosurge patients, so spinal or people that have had, brain surgeries, things like that. Those people I see. That's a large percentage of what I see, but I'm a neurotherapist. So that's why. I had a total hip the other day and I was like, you're fine. Get out of here.
Are there patients that you have been unwilling to see? You approach their house and there's just will you characterize A, the frequency of that experience, and B, the experience itself? A patient who you leave. This isn't for you.
There's only been one that I left before I got into the house. And the best I can say is, in like horror movies, when people say that there's like a vibe around the house and they're like, oh, this house is creepy. It was that. I walked up to the door and I was like, nope, I'm out. And I just turned around. I called my manager. I was like, you need to send the biggest dude we have because this is not a good place. Gosh, who else did I left a house. I walked in and his friend was in the kitchen making a whole loaf's worth of peanut butter and jelly really fast. He was clearly like methed out and he was just making it and telling me how much he loved his friend. And he was, oh, take care of him. And I was like, okay, I'm going to go. And I found the friend, the patient. He was in the back of the house, but he was absolutely drunk. And I asked him to get up so we could walk. And he grabbed a metal pipe and he was swinging it like this, like swinging it around. But he was so drunk that he kept bonking into each of the walls in the hallway and falling down. So I was like, I'm not really worried about you. But I did not go back because of the weird meth guy making sandwiches. I was like, we need to send a gentleman there. And I carry mace in my pocket and I carry all my stuff in my pocket. So my keys, my phone, my ID, credit card, all of that kind of stuff. So if I have to leave my bag, there's nothing in it that they could use. And if they keep my computer, it shuts down and is locked. So they couldn't do anything with it anyway. But I keep my stuff with me and I do carry, but some of my coworkers do carry guns. And they have had issues. So I thankfully have not had to use that. But
on the subject of guns, you and I have talked previously about your gun encounter, at least one of them. But you ended up treating that patient, right?
I did.
Okay. Will you tell the story?
Oh, this patient. She was crazy pants. She was not just crazy pants like, oh, I think you're a little bit weird. She needed to be in an institution, I think. She was bedbound and I was there. I showed up at the time that we agreed on and I was knocking on the door and I heard her screaming at her caregiver and I thought, why is she being so mean to this caregiver? It's so weird. This caregiver's nice. And no one was coming to the door. So I went to the front window where I knew her bed was. Her hospital bed was in the front window. And I went, knocked on the window. I said, hi, it's me. And she just pulls a gun out. And I was like, whoa. And I ducked and I sprinted to my car and I got in my car and I drove away a couple blocks. And I sat there and I calmed down a little bit. And I called my boss and asked what I should do. And he's like, nothing. It's her house. And I was like, oh, yeah. So I called the caregiver and I said, where are you? And she goes, oh, I'm just at the store. It's fine. Go in. I'm like, no, she has a gun. And the caregiver said, oh, no, we just let her have that. It's not loaded. We give her that so she feels safe. And I was like, I absolutely do not have a way of verifying that. No, I'm not going back. So she goes, well, just go to the front door. There's a credit card in the little mail, like the newspaper holder thing. She goes, just get that out and Jimmy open the door. That's how I get in. She won't give me a key. I'm like, I am 100% not breaking and entering ever. So I waited until the caregiver came back and then we just walked in and she was so demented. She couldn't remember it and just said, hi, like I hadn't been there, as my blood pressure is like 500 over 200. But she was like, oh, hi, haven't seen you in a while. I was like, really? Because you just pulled an empty gun on me.
Did you see her multiple times? I mean, like after that, were you returning to see her?
Only for a few more. She was towards the end of our what we could do for her. So just a few more, but I did. And she had interesting things. Like she had her son's name painted on the ceiling, and it said, I forget his name. It was like Josh. It was like, Josh is hungry, and it was painted on the ceiling. I was like, did Josh die here? I don't know. He might have.
At some point, I do think you need to publish the memoirs of working in neuro PT, home health PT.
Oh, there's several of us that do home health that in all the disciplines have said, like, I think it's 7 years and they can't sue you anymore. So maybe we should all just write a book. Like every 7 years we update it with people that, there's never a boring thing. So that's one of the things that attracted me to home health, was that you will never, ever be bored. And if you like to MacGyver things, like a patient doesn't have the money to buy a shower chair and Medicare doesn't cover it, you have to figure out how to MacGyver their lawn chair into their bathroom and make it not slip so they can take a bath.
Do some of your coworkers and colleagues, have some of them just quit because it's too much?
Yes, mostly nurses.
Okay.
PTs tend to have the better end of the deal. Nurses, they tend to get, one, they're paid less. They can make more money at the hospital, so they usually leave to go do that. But PTs, we tend to make a little bit more in home health. And so we're okay with a little bit of that. And we tend to be, I think, kind of more go with the flow type of people anyway. So we're like, oh, you don't have a leg. Cool. Let's figure out what we can do. So we tend to stick around a little bit longer. Have you observed hiring PTs with specialties? Okay, so the hiring of specialists and do you mean like people's assignments have been based more on, like you get a job with, say, a Medisys, which is a national company, and they might say, hey, you're just in 37205, like that zip code. That does happen. That does happen at my company. But when I was hired, I just said, nope, I'd rather just see my own special patient caseload and I will help out. And they were like, cool, that's fine. So my company was fine with it, but a lot of them do have zones, zip codes. They will hire specialists, but in PT, it tends to be either ortho for like your total hips, your total joints for home health, or wound care. So I am one of only 2 that I know of in town that do home health that are neuro specialists. The rest either work at rehab or outpatient. It's just not a very hired specialty right now because they don't know what to do with us. But yeah, we do have that. Most people are assigned an area. So you just have to advocate for yourself. If you want to sell yourself as a specialist, then be like, that's what I'm being hired as. Stop.
How many physical therapists, people who go through school, what their ambition is before school, what they think physical therapy is before school, what they assume they'll be doing with their lives, how many of those ambitions are fulfilled as the expectations sort of illustrate them? And how many people step into a field that is nothing to do with what they expected?
From the PTs that I know, that I'm close with, none have left PT as a field to go do something else. Many of them have changed what they thought they wanted to do in PT school, or even after PT school. They thought they wanted to be in geriatrics, or they wanted to go into the school setting, or they wanted to deal with obese people or whatever, and then they changed. I think I've always liked neuro. I don't remember hating it, so I don't think that I ever changed mine, but there are people that will want to change their specialty, and then some people that thought they wanted to be in a special area of care. Like I have a friend who did wound care for many years, and then she just decided she wants to do general, and she got a job in acute care on all the floors.
So is a sense of adventure critical?
For home health, yeah.
And then for other disciplines in PT, it just sounds like an open mind is necessary to get those broad exposures to the different divisions of physical therapy and be open to which one is interesting.
Yeah, I mean, you have to experience all of them. And I would always say to start with the easier stuff, because I know new grads that want to go straight into home health. I actually just finished up with a student on Wednesday who wants to go into home health. And I was like, yeah, but you should probably spend a little time at the hospital first and spend a little time in an outpatient clinic and get to know the places where your patients are coming from and where they're going. But while you have colleagues around to help you, and you can learn kind of how to hone those MacGyvering skills.
So there's probably very little repetition in your job other than the paperwork.
Very little, unless I have a surgical patient, like a total knee. Yeah, it's kind of a protocol type thing. And so you're just like, okay, fine, whatever. Do you remember your hip precautions? But if I have someone with Lewy body dementia, oh, that's fun. We're going to try music. We're going to try lights. We're going to try all kinds of things. So what does it say? Okay, so if I can't see the patients as often as I used to, is their progress slower? Sometimes it can be. I find that since we get cut off, again, my company is very good about letting us go over. So if I say I need 32 visits for a patient, they've never told me no. But it does make our margins pretty small. But yes, sometimes it does make us make the patients have slower progress, or they don't progress as much as they need to. So it progresses fast, and then we say, okay, you're done, and they just never go anywhere from there because we didn't get to do the follow through. We didn't get to maybe have a couple weeks where it was more like maintenance care rather than constant progress. But pretty good at following their long-term plan instructions. About 50% of them do what we tell them to do. That's about it. In outpatient, you have higher adherence to the plans. In home health, people kind of go back to their old selves when they get discharged. Yeah. Sometimes we have compliance, sometimes not. I think if you're good at explaining why people should be doing what they want to do, then they'll do it. I've found that just telling people, hey, do you want to stay out of the hospital? Then listen to what I'm telling you. If you want to go into the hospital where they might put you in a skilled nursing facility afterwards, fine. And some people still continue to not do what I tell them, and then they go into the hospital. But most of them, that's their goal, is to stay out of the hospital. So they'll respond to that more. Favorite and least favorite part about my job? Okay, it's my favorite. I get bored really fast. So my favorite part of the job is that it's always interesting. And it's always, I have to solve so many problems. It's like just always exciting. And very challenging. Like if I'm not staying up on top of new tests that people are getting, or new medications, then I'll get totally lost. So it kind of keeps me focused. And I like flexibility. Home health is really good for flexibility. So like if I wanted today off, I could just schedule all my patients the first 4 days of the week and then be off, as long as I met my productivity and all that other stuff, which I did, which is why I'm not working today. And the least favorite part is the paperwork. It sucks. And Medicare, they suck too. Okay, what is the frequency that you see patients? Between 1 and 4 times a week. So if it's a pretty simple surgical thing, total knee, here's your homework, here's your walking program, here's some education, we're going to talk about some stuff, I'll check on you next week. If it's like a new stroke, then I'm going to see you 4 days a week, and nursing's going to see you 3, and occupational is going to see you 3. So it just depends on what the patient needs and when we can get out to see them. Do you have a couple conditions? Yes, especially me. I get a lot of people with strokes, a lot of people with, sorry, phone keeps going. A lot of people with Parkinson's and ALS and MS, all the types. That's always interesting. And I still get like the lumbar radiculopathy and paresthesias type of thing, which is pretty straightforward and usually pretty easy to treat. I do get other types of conditions, but all their situations are so different. So if I have a patient that has Parkinson's but has a supportive family and they can afford to get different pieces of equipment, we'll make more progress. If I have a patient who lives by themselves and has end-stage MS and has no money, then we're limited to what the government will pay for, which is not much. So it depends on what's that?
Are there some patients who you can't do anything for? You walk into the house, you assess the situation, and go through that day one, and on day two you have decided there's just no involvement for you in their, I mean, there's no rebound to where they are. Is that a patient that you sometimes encounter?
Yeah, but it's not common.
Okay.
If there's a patient that I decide day one that they don't need us, it's usually a patient that's doing too well. If it's a patient that's unsafe and the house is unsafe and we shouldn't be in there, then I'll say there's nothing we can do. You need to have like a social worker come out. But usually I give them a couple of weeks, and if they're just not compliant or their health is failing, then I'll have to sit down and talk with the family. I actually have to do that next week. I have a patient who needs to be on hospice, and they are not ready to admit they need to be on hospice, but it's going to be time. So we're going to have a come to Jesus talk. And since I'm in Oregon, I have probably had to have several talks every couple of months about death with dignity, which is not something I was prepared to talk to people about as much as I do.
Can you expand on that part?
What it is?
Yeah. And what the talk is like, and just the paragraph version of that statement.
Well, since patients bring it up to me, I don't ever bring it up to patients. They usually say, how can I get that? How do I go about that? And I have to say, well, you have to have 2 different physicians agree that you have less than 6 months to live. You have to be able to go to the pharmacy, fill out your prescription, open the bottle, and take it yourself. Very few people get kind of dispensation, I guess, or special permission to do liquid. It's a pill. I've only ever seen people that wanted the pill anyway. And you have to be able to take it yourself. So I just tell them, like, we'll sit down and we'll go through, do you have a will? Do you have your advanced directives for finances and everything else set up? Do you have everything tied up financially with your house? Do you have kids? Do you have all that kind of stuff? Do you know where all this paperwork is? Do you have things set up in your house? So we'll go through all of that. And usually they do. They're just ready to be done. Sometimes, like I've talked to a gentleman that he was dying and they couldn't fix his brain tumor. And I sat in the living room while he asked about it, and his kids and his wife were right there, and they did not want him to do it. But he was like, I can't let you guys be financially ruined because they're going to keep me alive a little bit. I mean, he couldn't even sit up. He couldn't do anything. And it just progressively getting worse and worse, but he was probably going to live for at least, I would say, around the 6-month mark. And he said he didn't want his kids to be like in debt forever because he needed to be in the room. So that was a weird conversation, but I just tell them what qualifies them for death with dignity and how they have to go about doing it. And if they want, then I'll alert their physician, their PCP, who then has to call in for another opinion. But that's pretty much it. Yeah. Oh, sorry. I think I missed a couple. Hold on. How do I handle the emotional part of working with these patients? If they suck, I usually yell. If they're really sad, then there are times where I barely made it to my car. and I just lose it. I'm just like, oh, these people is like, it's very heartbreaking. Most of the time, it's just like, if I get mad, it's usually the family. I'm like, why didn't you go get your uncle this medication? Like, what is wrong with you? But it does take an emotional toll. Yeah. I don't know many people in home health that don't have coffee and alcohol just all the time. Are you trained for those difficult encounters? Not really. No. It's just kind of learn as you go. I think most of us that, especially once you go through school and you deal with people, you deal with all that people have, all that they come with. So you're kind of trained for it, but no, nothing specific. And does a social worker come in with you? Nope. I can ask for them. We do have a social worker at our office. Not all home health companies have a social worker. We do. But no, they don't come with me unless I specifically ask them. But most of the time that I've been asked, it has been just out of nowhere. Like I'll just be working with the patient and they'll say, hey, what about this? So I don't have time to prepare. Yeah, it's not great to talk about that. I'm a lot less lenient with patients who don't listen than I used to be, because I just don't have the time. There are patients who want to get better and I would rather spend my time with them, but I'm also a lot kinder to older people. Especially ones that are not, they don't have their full capacities. I used to kind of be more dismissive a lot towards those patients and be like, it's a memory care eval. Okay, fine. We'll just go in, we'll see the person. But talking to them, especially just over these last 8 years, has taught me to kind of view them as people and think like, oh, this was a picture of them at their wedding. Like they have a whole story, a whole life behind, even though they can't remember all of it, it's still there. And so definitely there's a lot more softness for treating them as a whole person. When I used to kind of just want to get it done clinically, I was just interested in what was wrong with their body, and then that's it, and I'm gone. But it's definitely softer in that sense. But I'm also a lot meaner if someone's not listening.
I'll just unmute and ask my question with a mouth that you can't see. You said, this initial intake where you go through all the paperwork and the eval and do everything from skin to neuro to everything. Do some of those older patients take longer? Do the sympathetic the patients for whom you have more sort of compassion or like a little tender spot for, does that take longer to do the intake on those?
Probably. I probably don't rush it as much. Yeah, I mean, if someone's really mean, I'm not going to sit there and spend extra time with them. But yeah, if they're a patient that is, just really kind of a special person, then I might actually just sit there and do non-PT stuff and talk with them. I had a gentleman not too long ago who, his memory is actually pretty good. He's like, 98, 99, and just a little bit maybe confused, but he just wanted to sit down and talk about his wife who had died maybe 3 years ago. So I sat for like half an hour and just talked with him. He was so sweet. But I don't always do that, no.
Does your schedule permit that? How many patients, like, if it's a physician at the hospital, it's every 15 minutes there's a block. You go over 5 minutes on one, you got to cut another one short 5 minutes. How structured is your schedule?
Not like that.
So there's an elasticity where you can, okay.
That's part of the allure of home health for a lot of people, is you get to make your own schedule. You get to, you have flexibility. Like if I want to cut my day short and go to dinner with my husband or something, I can. I'll just scooch my schedule around. And you get good at seeing, like, predicting how long people are going to take. So if I see a diagnosis that says, knee pain or something, well, that's a quick visit. I'm not going to be there for 2 hours. There's not that much to the knee. It's just not that interesting. Now, if I have a recent TBI, then I know to give myself 2 hours and then another half an hour for documentation and then another person. So it just depends on, if you know the patient, you get used to their diagnosis, you can kind of make your days fit your schedule. And there are limitations, like I have to see certain people on certain days for insurance reasons, but other than that, there's a lot of flexibility. There's a lot of flexibility. And my company doesn't really question anything as long as my people don't die. They're pretty good. Okay, well, I'm sorry, where was I? Oh, my Prader-Willi syndrome kid, yeah. So, did you tell him about him? Okay, all right.
I've mentioned it very, very sort of in passing.
Oh, okay. So so back in a graduate school, my dissertation was creating a protocol for PWS, just a standard protocol for certain issues that people tend to have with that genetic disorder. And I couldn't get it small enough to publish ever. And we tried to get a series in multiple journals, and they all just laughed at us and said no. But anyway, so it was never a published protocol, but I did create a protocol, and I actually finally got a PWS person in home health. He was 27 at the time, I want to say, because I saw him for like 3.5 years. Yeah, and he was like 30, maybe he was 28. Anyway, and I implemented it as far as behavioral strategies for getting him to comply to treatments. And well, there was home safety involved. And then also strengthening for certain disorders that he had. So he had severe scoliosis. He had a lot of limb issues. Yeah, my biggest focus for him, for this specific patient, was the behavioral, because he was not adherent to any kind of program. But part of the protocol that we kind of created was making sure that physicians and everyone, they're aware that people with PWS don't really see inherent value in tasks. So everyone was just telling him to do things and he wouldn't do them. So I found that his was reward-based. So I got him to do everything I needed him to do all the time if he got a reward. And I made the reward very personalized for him, which it happened to be Wii dance-offs. So I would tell him, his name was Nick, that I said, Nick, we could do a Wii dance-off if you will do this. We'll practice your stairs outside. We will do this. And then your homework is you have to not break into the refrigerator and eat for these many hours. And if you do that, we can have all these Wii dance-offs. And I legitimately lost quite a few of those. But that was the biggest one, was the behavioral aspect of learning how to treat these people and their individual values. It was very cool. Him specifically, because he had already developed, I didn't get to implement as many of the physical things as I would have, because I would have seen him as a child. So he already had some of the bone issues. I wasn't going to fix all of those by the time he was an adult, but so I didn't get to implement the whole protocol. It was more the behavioral part. But Court, did I tell you he passed away?
No.
Yeah. So I knew he had gone to a transitional care facility, and I actually only know this because my friend is the dietitian there, and I had told her about him because we'd worked together for so many years that he was my friend. Like, I mean, he would just call me, we would FaceTime, that kind of stuff. And she said, hey, Nick is at our facility. And I was like, oh, okay. So I went to see him, and he wasn't doing well. This was pre-COVID. And then sometime over COVID, she called me and asked if I could come by. And I said, yeah. She goes, well, I have this present for you. And it was a painting he had done at the facility. And it said, to April, love, Nick. And I was like, oh, that's so wonderful. And I thought, oh, I'll have to message him. So I did. And he never got back to me, which was very strange. And then she called me one day in the middle of the day and was like, hey, I figured you'd want to know that Nick had passed away. And I was like, oh, but I had this little painting from him. So he had respiratory failure.
You still have the painting?
I do have the painting. It's in the house.
Okay. Are there patients like this one you learn from in terms of like a contingency management approach? You know, we'll have our dance off if you don't, if there isn't too much refrigerator activity, we'll have our dance off. Were you able to employ that sort of management style, that reward system management style in other patients, or is that just a one-off and then you move forward unchanged? Are there certain patients that change your way of giving care?
Yeah, I mean, my way of giving care changes with the patients because it's very personalized. So for Nick, I would love to say what a typical treatment was like for all people with PWS, but it's different. And it was highly specific to, it was like treating someone with Lewy body dementia. There is no typical, there's a protocol you can follow, and then you pick which parts of the protocol actually worked for the patient. But I guess my treatment just changes based on what they do, what they respond to, like telling them they're going to stay out of the hospital. That's a good one. That might be standard.
If there was advice that you could give to yourself when you're a beginner, your first week on the job in home health as compared to now, is there advice you wish you could impart on your younger self?
Yeah, you're not as good as you think you are. You will always grow up, and you better be able to admit that and fix it. Because there are people that will absolutely not admit it. And I was one of those people. I was like, no, I did a really good job here. And looking back, I'm like, oh, I really screwed that up. That was real bad. And I think that's true of any healthcare practitioner, especially, when we're given a lot of information and a lot of knowledge, and we just are like, we know all this stuff and we can fix all these people. And we don't realize that you can't know everything about the human body. There's just no possible way. So you have to admit that you need a team. It needs to be a collaborative thing. And don't try to be like, oh, I can do this all by myself, because you can't. Even though in home health you're by yourself, but I still, will call up my boss and be like, oh my gosh, I don't know what's going on. What's happening here? And they'll help.
Are there some specific, so it sounds like humility is necessary for the job. Humility and honest self-reflection are necessary for improvement. But are there some specific people who you call for, if the patient is of this category, or the patient is exhibiting these symptoms, do you have some particular people that you would call for input?
Yeah. So one of the things that, especially being home health, is I tend to I form more relationships with the physicians because I'm communicating with them a lot. And then it just happens that I have more like personal relationships with a lot of the physicians. So honestly, there are PTs that I will call, like there's wound care PTs I will call. There's PTs that do total joints, like total shoulders, that I've forgotten all about, or PTs that do ankles that I've forgotten all the ligaments to. I will call them for those specific things. But most of the time, if there's a really big question, I'll call a neurologist friend, and I'll just be like, Emily, what do you think this patient has? Because it sounds to me like, it sounds to me like they're having, a Cotta-Equina syndrome issue, but they're a year out and it's not going to be fixed. Is there anything we can do? And she'll be like, they're screwed. So, I do actually call physicians probably more often than I call coworkers, because my questions are not usually PT related. And as just a side note about how they they lie to physicians. They're going to lie. They're going to present their best selves to the physicians. So I had a patient who was one of the train wrecks. They lived in a fifth wheel off of someone else's property. She was bedbound, and the bed took up the whole floor area. It was not a good situation. And I happened to be at a party, and a physician who's a friend of mine was there, and I hear this, April. I'm like, what? And he goes, my patient lives in a trailer? He had no idea. She said the address was the house and she lived in the house. I'm like, no, that's the house on the property. She lives behind the house. And he was furious because he had given her all these instructions and all these pieces of equipment that don't fit in a trailer, like a literal camping trailer, not like a mobile home. And he had no idea. She had just kept putting the address down. Didn't know that she lived in a trailer, and didn't know that her husband had just had open heart surgery and could not lift her. And he was furious because he sent her home. And he's like, I wouldn't have sent her home on home health had I known that her husband couldn't lift her and she lives in a trailer. So sometimes you have those communications with people because he had no idea. Okay, sorry. Any experience with collegiate no, I don't. When I worked in Tennessee, I worked for a company in Nashville that had the contract with the Tennessee Titans and the Nashville Predators. And we all vied to be part of that group. Everyone did, except for me. I would be the worst sports therapist of all time because they would say like, oh, it hurts when I hit guys playing football. And I'd be like, stop playing football. And then they would fire me. So I don't work with athletes. I don't think I could do that. I'd be fired right away.
Are there parts of your job where you know the treatment or the type of interaction or whatever your engagement is would be effective, but you have to withhold owing to liability? Is there just like, oh, the liability attorneys would kill me for this, but I know it would be better? Are there specific interactions or treatments that you know would be more effective, but you can't do? Or is it just free game?
I don't usually hold back. I'm sure there's probably some instances where I probably in a court of law, they would be like, so why did you do that? I'd be like, but it worked. But no, I don't usually find myself holding back for treatment methods. I'm pretty creative. So I'm like, do you guys want to learn how to go downstairs on all fours backwards? Great. That's how we're going to do it.
And you haven't had any legal concerns?
Not yet.
Okay.
I did really piss off a patient recently, and I do wonder if she's going to try to sue me. She will definitely lose because I was not wrong, but I did make her very mad, and she fired me.
Can you, without betraying any breaching trusts or could you explain what that looks like? When a patient is upset and fires you and like, I don't want to work with you anymore, what leads to that and what the fallout is like?
So I have only ever been fired 4 times now. The first one was a knee patient that said I was too mean to her knee. And then she fired the next clinician that went out because she felt that she needed to completely rest her total joint. And was not a fan of learning how to walk. So she fired 2 of us. That one hurt my feelings a little bit because I was like, I'm doing everything right. And I was kind of new. It was maybe my second year of doing home health. And that one I was pretty upset about. I got fired maybe not that long ago from a patient who thought I let her dog out. So that was annoying because I was like, you are doing so well. She was a very difficult, very emotionally distraught, a lot of psychological issues patient. And I had managed to somehow make all these changes. We got her a new bed. Her symptoms were going down. Anyway, all these things. And she thought I let her dog out and called the company and was very upset and never wanted to see me again. So that one hurt my pride a little bit less because I was like, obviously I didn't let her dog out because the dog was in the house when I left. But anyway, so that one was just annoying. And then I guess the last one, so I've only been fired 3 times. The last one was a lady who misunderstood a conversation I had with her prosthetist. She felt that I made an appointment for her, which is just impossible. So, but she was not in a mental state to hear what I was saying to her, that I did not make the appointment, that her prosthetist did, and he forgot to tell her. And she was absolutely certain that it was my fault. And the prosthetist even was like, no, I had this appointment. So that was the only person I actually thought might try to sue me because she was really pissed for days. But
so with these patients, though, neuro patients, if you are working with somebody who has mental decline, it's probably unlikely that claims that they're making are grounded in some fact. Well, am I wrong in making that assumption?
That no, most of the time the claims they make are pretty out there. I have a very unfortunate reputation at my company as the person the crazies like. So when other clinicians will get fired for Lord knows what reason, I tend to do very well with their difficult patients. So if they're a patient with, you know, I had a patient who had vascular dementia and frontal lobe dementia, which leads to all kinds of behavioral issues. She was adamant that her previous therapist slammed the door and broke it, and the door came off the hinges, and all of this, which obviously it didn't because I showed up by knocking on the door. But I was able to treat her for the remainder. She really liked me enough to send me pictures of when she had explosive diarrhea. But yeah, the claims were very unsubstantiated. So she fired a clinician who was fine. And no one really put much stock into her claim. So, especially because there was physical evidence that it did not happen. So it's, yeah, most of my patients, especially if they have psychological issues, if they call and they're mad, then the manager's like, okay. I had a lady who didn't fire me, but did call and say that I stole all the carpet from her house. Just all of it, all the carpet. Pulled it up, took it with me in my Prius, apparently. And she called, but I was still there. So I was like, ma'am, why are you calling my boss? I'm right here. And she was like, April took my carpet. And I was like, nope, didn't. It's gross. Don't want it. So, but she didn't fire me. She just wanted my boss to know. And my boss was like, okay, that's not weird.
But your boss probably never takes any stock in these calls. They just informing you that there was a phone call. There's no need to talk further unless you have a good giggle you want to have about it.
Yeah, and both of the managers that I've ever had at this company were both PTs, and they still treated patients in the field, so they were well aware. There have been other clinicians that had to be like actually removed from clinic work for a while until things were sorted, but I have not experienced that. And document everything, every little thing, document the shit out of it. Like my coworkers mock my documentation constantly because it's the lengthiest. I mean, I will write pages about a phone conversation and they mock it, but if it ever goes to trial and I have to say I defer to my documentation, it's in there. It's in there, it's dated, everything is in there.
I have a question that's very similar to Hunter asked one in the comment box, but so I have one that's a lead into that, which is you mentioned the managers are PTs. Have you had managers who are not PTs and they don't understand the practice, and you go do your therapy and they don't know what you're doing, and that leads to disputes or misunderstandings?
Like, did I ever have a patient with low health literacy?
No, but did you have a manager, like some sort of either owner or manager of the company who isn't a physical therapist?
Yeah. So let me answer his question first.
Okay.
I have not ever had a past PT that I know of as a patient. I've had many physicians who have turned out to be the best patients because they're like, yeah, whatever you do is fine. The worst ones are patients who like their cousin is a CNA. Those are the worst because they like know everything and it drives me absolutely crazy. Then Courtney, your question yes, the CEO of our company is not a clinician and he has less than no idea what we do. And he tries every so often to be involved. And we have to be like, you don't.
We are recording.
Yeah, but no, he doesn't. He doesn't understand what it's like to be a clinician because he's not a clinician, which is why he relies on managers. So, yeah. I've not had anybody above me question my treatments. What?
The managers are PTs, but there's still some problem, it sounds like, in some of the communication of dealing with people who aren't really in the field, but are on either the financial or the business side somehow.
Well, the managers, even there's nurse managers and PT managers. And they, even though they still work in the field, they have to be more business minded than we do. That's just because they're in the office and they have to look at, are we losing money? Are we going to have a job next month? You know, so we do get hassled about things. Then they might say, well, do you really need that many visits? Or, you know, why would you try to extend through this certification period when you don't really have to? And I do have to support myself, to support my reasoning. But it doesn't happen as much as I think it does with the nursing staff.
And your reasoning is generally supported.
Yeah,
They will sort of yield to the logic of the PT.
they have never not so far. So as long as I can come back and say, this is what I think is going to happen if we don't do what I'm saying, and here's why I think that, they haven't been able to refute it so far.
So we just have a couple of minutes left. Do we have some last couple of minute questions for April before she goes away forever and you don't get to ask? I think I can speak on behalf of everyone, certainly on my behalf. Thank you so much for showing up to do this. And
thanks for listening.
So many of our students are aspiring PTs, clinicians in either OT or PT.
Yeah.
And I think this will, the pre-PT club will probably watch this. And so I think it will have viewership among the aspirants. So I think this is really helpful.
Well, I hope it wasn't just, you know, listening to someone babble on, because you guys already have Courtney. You don't need more of that. But you,
I know nothing about PT, and so this is incredibly helpful.
But if people have, you know, questions specific that they might want to ask later, like, feel free to give them my email. And I would always suggest to shadow. You can shadow people whenever you want. They're pretty good about it. So if people are really interested in OT or PT, I would say shadow them in a bunch of different settings, because it's pretty cool. And OT is awesome. So it's a very cool thing to learn. But yeah, you guys are welcome to ask any follow-up questions if you have them.
I will share your email address just to the people here, not to, you know, campus wide. Well, thank you so much for scheduling the time to do this. This is our last class of the semester, and what better way for applied and clinical physiology than to have somebody in the clinical field applying this stuff.
I apply a lot of physiology.
All right. Well, we will let you go, and we will get.
Thank you guys. Have a good. While you're done, are you guys all done for the semester then for all your classes, or?
We'll have a final on Monday.
Oh, okay.
So, and we'll be up in Oregon. So maybe are you going to be in Oregon around the holidays?
Yeah, I'll be here.
I'll see you.
Okay, bye. Thank you guys for listening.
I see you, April.
Bye.